Well, thank you all for joining today. This is the first event for many of us of this really busy week, and I'm really glad to be getting you on a Monday morning before this week, because hopefully everyone will have great ideas and can really help drive the conversation. We have I like this kind of event because everyone can really participate, and the issue that we have on the table today, which is NCD financing, is really as important an issue as ever. I'm Alan Robbins. I'm co-founder and executive vice president of Devex, which is, as you all know, the media platform for global development and health. And I'm happy to be here co-hosting this event today with our friends from Boehringer Ingelheim, Access Accelerated, and AstraZeneca. This event is, I'll call it a satellite event of the Devex Impact House NCD Pavilion. Most of the Devex Impact House events are going on down the street. We have at Valbella at the park, a restaurant we've rented out. We have 3 days of events. Today, they're all on NCDs. And yeah, this is all, so we wanted to do a full day on NCDs because we have the HLM4 meeting, HLM4 coming up. And that's going to be sort of everyone's driving a political consensus, trying to drive a political consensus around NCDs. And that's great that people are coming together. I'm hearing generally positive things about sort of the outcomes, but we all know that financing is going to be a major part of the challenges that we face. And I think this room here is as qualified as any room to really help come to those solutions. So I thank you all for joining. We do have a fairly innovative program today where everyone's a participant and everyone's an audience member. To help get the ideas flowing, we are going to start with a couple of short panel discussions. The first one is going to be on sort of what's the state of play with NCD financing. So I will start that off right now. So can I invite our first panel, Dr. Frieden, to come up. Ulrika, if you can come up, and Dr. Jashi and Dr. Seeley Thomas, if you can come up. I'll go to the end here. All right, well, thank you all. Everyone should have, you see the screen here, everyone's affiliations, so I won't go through these very impressive bios. So Dr. Frieden, I think I'll start with you on, if you can just give us kind of a big picture, lay of the land from your perspective on where we are in NCD financing. What are the opportunities, both from the sort of big picture, sort of like domestic resource mobilization and also the aid sector, just a lay of the land from your perspective.
I think we need to fundamentally change how we raise money and how we spend it. The good news with NCD financing is that we didn't lose any money with recent cuts. The bad news is that's because we didn't get any money before. So in terms of raising money, the most effective way has to be health taxes. And this is the moment for health taxes. There is enormous opposition. Let's be really frank. The tobacco, alcohol, sugary drink, and junk food companies are brutal. They use corrupt and misleading approaches in many countries to pay off the government to ensure that taxes aren't implemented. But these taxes are very effective, even if they're not used for health, even if they're just used for revenue generation. And they have to be done very effectively. Sometimes when I hear public health people talking about health taxes, I think it's like an economist saying, we need medicine. You know, you have to think, what's the structure of the tax? How is it enforced? Who's going to produce it? Are there digital tax stamps? What are the ways to avoid leakage? What are all of the side effects that can be avoided? And all of that is addressable. But we have a very small world that's trying to counter a very powerful set of forces. So health taxes are crucial. Obviously, health insurance is also extremely important and part of universal care, because health taxes alone are not going to do it. And then briefly again on spending, my view, my opinion, is we'll be much more effective if we prioritize. Each country needs to select its priorities. Countries are in charge of their own health. They lead. They're responsible to their people. As an epidemiologist, I say, see what the burden is, see what the amenability is, see how you can make the maximum difference. And that might mean for the financing, the health taxes are actually the single most effective thing we can do to reduce NCDs. For health care, something like hypertension treatment and statin use is very low cost, generic, effective, and massively underutilized. At most, 1 in 5 people in the world with high blood pressure is effectively treated, and it's the world's leading cause of death. 1 out of every 5 deaths, more deaths than all infectious diseases combined, many at a young age, many that cause a great deal of economic dislocation and economic loss, as well as personal tragedy and healthcare system costs. So the WHO HEARTS policy, the recommendations for statins, which are even more underutilized than antihypertensives for those who need them, there's a commonality about these two treatments, which is they're generic and low cost. That sounds like good news. The problem is that means there is no company that's pushing them. So doing a good job means having governments understand what will really make a difference, see who's dying from preventable conditions. 1 billion people in the world today have uncontrolled high blood pressure. And because of that, more than 10 million will die this year, mostly from preventable heart attacks and strokes. See why we're not making progress. What are the barriers within our health system and outside of the health system? See what the pathway to progress is. See how our programs are really doing. Not some performative program that looks good and is a press conference, but something that actually saves lives in the field. Believe that you can make a difference, because we've made a huge difference. In the US, there was a 2/3 reduction in cardiovascular disease between 1960 and 2010. It's stalled since. But countries like Korea show incredible progress, 80 to 90% reductions from the global average to one of the global bests, with one of the best hypertension control programs in the world. And then create a healthier future, looking at the need for coalitions, advocacy, simplification, because complex strategies never scale, and figuring out systematic ways to overcome barriers, because there is a structural barrier to progress in NCDs, that the profit motive is against the health imperative. And rather than simply decry that, figure out how to overcome it. Who are the winners and losers? Who are the deciders and influencers? When are there windows of opportunities? Who are the best champions and advocates? And what are the partnerships that are going to win? I'll leave with one final thought. You know, Coke and Pepsi hate each other, but they collaborate to block soda taxes. We in public health, healthcare, primary care can collaborate with many different groups to promote health.
Great, thank you. And I know you're not the only advocate of health taxes here. I know Mariam from Vital Strategies is going to be our next panel, so you're not alone. I want to move to you next, Dr. Celia Thomas, and ask you, looking at, you sit at Bampoe now. You've been the chief medical officer of Antigua and Barbuda. Can you talk a bit about your perspective and how multilateral organizations like Bampoe might be able to support low LMICs on any of these? It might be health taxes, might be any, but what can you all do? What can we all do to help drive toward effective NCD financing?
Thank you, and good morning to everyone. I'd like to start with health taxes, and I'd like to thank the former speaker for introducing it, because health taxes on tobacco products, alcohol, and sugar-sweetened beverages have been proven to be effective in reducing the amount of time and the amount of money that people spend on behaviors that promote non-communicable diseases. An example is Mexico, for example. In our region, they introduced tobacco taxes, and the revenue they've generated, but they've put it back into public health. For example, in creating healthy school meals for children, creating healthy spaces. Mexico was able to raise over $2.6 million over 2 years when they did that, introduced fiscal taxes. So I think that is something that needs to be promoted throughout the Caribbean and Latin America, but also globally. The other thing is that I believe that the PAHO, the Pan American Health Organization, we have a strategic fund. And what that allows us to do is to pool the resources from all our 35 member states and use that demand and do demand planning in order to order or purchase medicines, vaccines, diagnostics for chronic non-communicable diseases and communicable diseases. And because we have that demand, that guaranteed demand, the drug companies and manufacturers are able to lower the price of medicines and diagnostics. A very good example is cervical cancer, non-communicable disease. Through the strategic fund, countries in Latin America and the Caribbean are able to procure the HPV vaccine at a reduced cost. But it doesn't end there. We're also able to provide the HPV testing, which is the good diagnostic test now and the gold standard to diagnose cervical cancer. And then the other thing that we do, we go even further. We facilitate the purchase of thermal ablation therapy for women who are diagnosed with cervical cancer. So through the PAHO Strategic Fund, we're able to procure vaccines, have diagnostics, and also provide treatment for a non-communicable disease. And by pooling the resources, as I have said before, we're able to reduce the cost for all three: prevention, treatment, and diagnosis of cervical cancer. And we do that for other non-communicable diseases. For example, for diabetes, we used pool procurement to purchase insulin. For hypertension, we do that as well for statins. So I think that is a very good strategy, a good financial strategy that is able to facilitate the creation of fiscal space so that countries have the opportunity to use scarce resources to more efficiently, for example. Thank you.
Great, thanks. And Ulrika, I'll go to you now. You're Secretary General of the Swedish Cancer Society and also President of UICC. So, this issue is not just an LMIC issue. This is a global issue, and you're seeing a lot of high-income countries pull back on their donor spend, whatever it might be. It might be health, it might be, agriculture, in all these areas. What do you think the sort of high-income countries can do to help? I mean, obviously, they're looking at it saying, hey, we have issues too, but then also, there's an obligation to help others also work on these issues. What do you think can be done? Especially, Nordic countries are staying in the game as it is.
Yeah, I know we can all see the shift that's happened in terms of development aid last couple of years, actually focusing more on humanitarian, moving from development to humanitarian, and also focus on what's happening near in your own sort of context. From a European perspective, is support to Ukraine now, moving away from a lot of low-income countries that's been supported by European development organizations previously. But I think what we can actually see is in order to, we won't go back to where we were like 5 or 10 years ago. I think what governments are interested in and what will happen is to really see that NCD strategies and national cancer control plans are costed, and that you can actually build the case, because it's quite hard to invest in something when it's not costed. It's hard to see. You really need to have also the government commitment to actually take this into action and have it implemented in a way. Because we can actually see a gap in having a lot of plans that are not really costed. You can't really see the investment case for a lot of the NCD plans that we have currently. And there are a lot of good initiatives, and we can build on models. For example, the Gavi and Global Fund model, and one example is the Atom Coalition, an initiative from UICC with partnerships with more than 40 partners from private and civil society sector to actually provide affordable, accessible cancer medicines in low and lower middle income countries. And it's a model building on the experiences from Gavi and Global Fund, but without the grants. It's a sustainable business model trying to work with governments to at the same time deliver medicines through voluntary license and pool procurement, and at the same time build capacity so that the medicines actually available are used and fits into the existing health systems. Because too often medicines are available, but they are underutilized, and that's a real waste. So it's not just about sort of reducing the cost, it's also about these waste can be reinvested into the health system. So it's just one very interesting model that I think we can develop also in other areas. But I think we also need to actually find the new ways of working. And we're all talking about collaborations, but I want to build also about on the health taxes, because I think what many donors would like to see that domestic funding is increased, and the best model is actually through very good tax systems. And I think a lot of donor countries, so to speak, are interested in developing tax systems for low-income countries and are willing to support that. It might not feel that sexy, but it actually works, and it's something that's sustainable for a long time. At the same time, we know that governments are not interested in earmarking funding for tobacco taxation, for example, or soda taxes, but they are really important in the system and for universal health coverage. And they don't have to be earmarked, but they are an important resource for governments to use in all health area, in all areas, to build resilience of the country. So I think it's all about building the economic case, have costed NCD plans, thinking about how to make the new financing models sustainable, so it's not just short-term grants. It could be short-term investment, but they need to be sustainable from an investment perspective. Many things to think about: health taxes, costing NCD plans, finding ways to balance it with domestic funding in order to make a difference.
Fascinating. And Dr. Jashi, you are currently Unite Chapter Chair for East Europe and Central Asia, but you've been a parliamentarian and Deputy Health Minister of Georgia. So you've, I'm sure, been very much in the middle of the conversations that Ulrika was just mentioning. What is that like, and what strategies have you used to help drive funding toward this issue?
Thank you for the opportunity. When we speak about universality and indivisibility of health, including the basic right to the best attainable standards of health, unfortunately, we are still very much dependent on the political will. Political will can be the single most important factor in making decisions and driving the change. And that is exactly what happened in Georgia 12 years ago when I joined the ministry as the deputy, and when more than half of the country's population didn't have any medical insurance coverage. 9% of households became impoverished because of catastrophic health expenditures, and the out-of-pocket payment for health care was 73%. In addition to the numbers and investment cases, what we need is the convergence of the public's perception of the problem and positioning the challenge in the political context. So what happened is literally inability of Georgian citizens to see a doctor was reflected in the polls, pre-election polls, and political parties were urged to integrate universal health coverage into their manifestos and political programs. And that was the single most important determinant. After the winning party became in the became the ruling party of the country, immediately health sector budget doubled. We even reallocated funds from military and other sectors. And as a result of basic UHC package, of course, not everything can be included. Every country has to package UHC based on its available resources, both infrastructure, human resources, and financial, of course. The out-of-pocket payment reduced from 73% to 54% in just 5 years. Incrementally, we integrated cardiovascular medication as still the major driving cost of chronic diseases, and the out-of-pocket payment is on decline. But is it enough? Of course not. There is always room for improvement, and especially for mental health. Today we're discussing NCDs and mental health. I don't believe any of the low and middle income countries has done good with mental health in terms of decentralization, integration into the PHC, because we're not only speaking about financing, we're speaking about capacities to deliver evidence-based and human-centered care.
Great. Great. Well, thanks so much. And I must say, I'm remiss because that is such a huge, the mental health side of it. And I've been saying NCD, 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 and it really is NCD and mental health. So it's really important. I've been fascinated by this conversation about if we were sitting here 5 years ago, I think that the amount of talk about donor funding would have been 90%, and the amount of talk about domestic resource mobilization, domestic agency, would be about 10%, and now it's flipped. So I'm not going to say whether that's good or bad, but it is an interesting switch. There's probably a lot of good things about it, and there might be some negative things about it as well. But with that, I wish we had more time, but we, alas, do not. So I want to thank you, and please join me in thanking.
Thank you so much. Delighted to introduce the next panel. I think if you can all come up to the stage, that would be fantastic. I think we've just heard a great discussion in terms of, we already know what works, whether it's hypertension management, we already have some of these solutions, but unfortunately, we're not seeing yet the level of investment at country level that's needed. When you look at the NCD burden, I think everyone in this room is very acutely familiar with it in terms of it driving huge amount of mortality. Of course, devastating for individuals, families, communities, but also healthcare systems and the economy. So I think really looking forward to hearing insights from this panel in terms of how can we move from these big commitments at the global level to scalable, impactful programs that can really make a difference at country level. So without further ado, I think we start with you, Victor, in terms of the fantastic work that you've been driving in Ghana in terms of the national health insurance model. And really curious to hear from you in terms of how you're thinking about the need to shift resources and spending on NCDs and mental health, but also how you're bringing partners along, looking at the financing at the country level.
Thank you very much, and I'm delighted to be here. And I'm not sure whether the work that we're doing is all that great. I think we're pushing on it. In Africa, we seem to be a place where people from different African countries to come and learn what we've done. So when we started off with the health insurance scheme 20 plus years ago, the focus was on non-communicable diseases, so malaria, gastroenteritis, and so on. Because of the epidemiological transition, we've moved to a point where more than 40% of our all-cause mortality is from non-communicable diseases. So we've actually begun to shift what we're focusing our funding on. And most of the funding comes from taxes. So 2.5% of our value-added tax goes into a fund that is used to pay for people who come to these hospitals. So I'll talk about 5 things that have actually helped us to transition from funding only communicable diseases to non-communicable diseases. The first one, and I think Dr. Jashi talked about it, is leadership. We have a president who is very focused on actually looking at how he can change things around. And we also, I think, subscribe to the saying that never waste a good crisis. So when the stop work order came and funding was not coming through, at that time the government had just changed. So the president decided that he should look within the budget to find money to plug the gaps. And then we also came up with what is called the Ghana Medical Care Trust, which is solely focused on non-communicable diseases, heart disease, cancers, and so on. So 20% of the funding that currently goes into the National Health Insurance Fund goes specifically to the Ghana Medical Care Trust, which is then focusing on non-communicable diseases. There's also funding from philanthropic organizations, from businesses, and so on. This is growing. So that's number one. Number two is also looking at finding efficiencies within the current National Health Insurance Scheme, which I must admit has a lot of leakages. So making sure that this can be plugged so that we get more mileage out of the funding that goes through. Number three is, I think, the most important thing, and that's the mindset shift that has been garnered throughout government, where starting from the president right through to the Minister of Finance and so on, the feeling is that healthcare is no longer a cost driver, but it's a focus of investment. So the Ghana Medical Care Trust is looking at screening, vaccines, prevention, promoting health, picking up some of these diseases quicker so that in the end, we don't have to be spending as much on the non-communicable diseases, but we're catching them much earlier. I must say that this is still work in progress. We're all eager to learn how it will go, but we're very excited, and other countries from Africa are always coming to learn from what we're doing. And we'll be sharing the examples as we go along.
Thank you so much, Victor. And I think all of us, health seen as an investment is absolutely what we need governments to look at, to commit to acting earlier, whether it's early detection, earlier screening, and making sure people can access the right care at the right time. Moving on to you next, Dr. Mariam Etiebet. I think, in your current role as CEO of the Vital Strategies, but also your previous work, would really love to hear some insights from you. How do we move from these often successful pilot programs to something sustainable, that can drive long-term impact with the proper financing in place?
Thank you so much for the question. And you use the term financing. I think that's critical for us to think about. This is not about funding flows. It's not about one-way funding flows. It's about creating markets where financing can flow in multiple directions. And so, Tom mentioned, what do we need to do to get to scale? In order to get to scale, we need to create healthy markets, and markets that don't just create wealth, but create health. And you've heard from the first panel that health taxes are the #1 proven solution that can get you there, not just at scale, but can get you there quickly. We talk about the triple win with health taxes. It generates revenue. We saw when South Africa introduced its sugary beverage levy, they got, I think, about over $300 million in 2 years. They saw a 30% reduction in consumption of sugary beverages. And so when you think about what else gives you those types of results quickly at scale, and they actually don't cost anything. It's, buying your pen and signing a policy document. And so I was so excited just to hear all of this enthusiasm about health taxes. And, Ghana, actually, you're a leader, in advancing health taxes. And the other important part about health taxes that we don't talk enough about, but Dr. Jashi mentioned it, is how we can use it to engage with the public and engage in dialogue with the public. Because in order to actually accomplish health taxes, we've heard how hard it is because of the industry, industry resistance. We have to be able to pierce through industry myths and come together to actually share what is happening. One of the myths out there is that it's just too difficult to do. It's too complex. It's too politically impossible. But that's actually not the case. We did a study looking at the state of health taxes on the African continent. Over 90% of countries have some sort of health tax in place. Some sort of health tax in place. There may not be good taxes. They may not be designed to capture the full public health benefit, but that's a starting point that we should all be mobilizing around and working with governments to say, not only do we know what to do, we know how to do it, and we know that it can be done. We know that it can be successful. But it's only successful when you bring in the public and have a dialogue with the public. When you survey the public, over 80% are for taxes, especially when you talk about the benefit that can accrue from them. And that's what drives the political will. And it's exciting for me that this is another opportunity in this moment in time, not just to think about how we create sustainable domestic financing, but how we bring the public back into public health. Because unless we do that, unless we engage in dialogue with the public, none of this will be possible, because we need their support in order to do these things that are difficult, but these things that are going to have continued benefit, not just today, but dividends in the future, because our young people, these are the folks who are getting hooked on and addicted to these harmful products. And we need to stop that before we get to a situation where we have more than half of our growing adolescent population, young adult population, having non-communicable diseases, and the burden that is going to create on health systems, which we know even now are not able to meet the demand that is out there. So just really heartened to see the focus on health taxes, the mobilization around health taxes, because that is the sustainable source of domestic revenue that's going to allow for all of us to advance our own priorities. Because at the end of the day, government is the biggest purchaser of health. Markets work when you can connect consumers, to suppliers, and when you can aggregate, across different sectors.
Thank you so much. Turning to you next, Dr. Kimberly Green from PATH. We've actually had the pleasure of collaborating with your organization on the Healthy Heart Africa program, where we look to integrate hypertension screening into primary care. And just was hoping you could share with the audience a little bit about the role of public-private partnerships, but also more broadly, where you've seen in the work that you do at PATH that we're really able to scale programs and drive long-standing impact.
Yeah, thanks so much for that. It's been an honor to partner with AstraZeneca on Healthy Heart Africa. And I just say in general, given the current environment and challenges that countries face right now with, the majority of premature deaths occurring for NCDs in Africa, with the complex financing environment, particularly with the stop work order and many countries having to make very sudden decisions on how to reallocate their resources, their workforce, their supply chain, and so much more. Partnerships really matter, and stable long-term partnerships that countries can really count on to support learning. And so that's really where I think public-private partnerships play a fantastic role. They can bring forward catalytic ideas, experimentation, new learning through strong partnership with governments and with communities on trialing something on a small scale, but a small scale that's built for scale up. Really building in those early learnings and applying them incrementally towards scale. And so I will say that while there are some amazing PPPs out there, not all of them have scaled. Some of them are very good, but some of them are great. And so what are the characteristics of a great PPP? And I have to say, through our experience with Healthy Heart Africa, we've really seen this come to life. So we've been partnering with Healthy Heart Africa since 2016. We've reached more than 5,000 individuals with screening services. We've done this across a number of countries, including Kenya, Ghana, Rwanda, Senegal, and Tanzania. And the key heart of this approach has really been, number one, on true partnership, bringing a lot of humility, a lot of co-creation and alignment with government priorities and community priorities, which are largely primary health care and largely community health workers, and really embedding practical NCD screening and treatment through those systems. So supporting those systems, strengthening them, number one. Number two, consistent commitment, really staying the course for NCDs and not shifting midway. And number three, an adaptive vision. So while the focus of this initiative has been on cardiovascular disease, it's expanded to include chronic kidney disease. And so really seeing and adapting the learnings over time has been critical. So I would say that those are the elements of a great PPP, and what we've seen through this partnership is then scale up and adoption of these approaches, very strong partnership and adoption in Ghana, in Rwanda, and in other countries. And I would say that of course, there are many other fantastic PPPs that are out there, and I would be remiss if I didn't mention the Coalition on Access to NCDs and Medicines, which PATH has been a part of with many stakeholders and members in this room, including Novo Nordisk and Access Accelerated, Ministry of Health in Kenya and Uganda, and Egypt, many other countries. So this coalition really focuses on bringing together stakeholders across academia, ministries of health, private sector, NGOs towards common cause of increasing access to NCD medicines and products through practical tools, through planning support, through forecasting, and through simplifying services such as for diabetes. And with that, I'll stop there. Thank you.
Thank you so much. Last but not least, turning to you, Herb, and really I think, we're all sort of, it's fantastic to see that in the draft high-level political declaration, there's reference to sustainable financing, and I think we are all kind of, wanting to see this come through. But would really like to hear from you in terms of the work that you've been leading at Access Accelerated. What is it that you hear from countries in terms of their priorities, the insights that you've got from the work that you do directly with countries, but also with many of your partners, and how are you sort of addressing this challenge of moving from pilots to something more sustainable?
Good. Well, thank you very much, and good morning, everybody. Access Accelerated is a collective effort of pharmaceutical companies working in partnership to help countries address NCDs. 2 years ago, we looked at our technical partnership with the World Bank, and together we decided to focus on sustainable financing for health, and in particular NCDs. And looking at where we are today, I'm glad we did. There's so much work to be done. We decided to co-create something called the Financing Accelerator Network for NCDs, or the FAN, working with Results for Development. We appointed a local partner in Africa, the African Institute for Development Policy, and we'll also be appointing local accelerators in Latin America and Asia. And really the FAN is built on a conviction that meaningful progress happens when countries are engaged. Countries are listened to, we understand their needs and priorities, and then we provide the technical support necessary in a very targeted way to address local needs and priorities. And so basically the FAN supports countries through technical assistance, through cross-country learning opportunities, and catalytic seed funding to advance promising health financing programs that may not get off the ground for lack of some startup capital. And I'll give you an example of how this works. Last month in Nairobi, we held a cross-country learning workshop on health financing for NCDs. And we were very pleased to have 7 country delegations turn up. We had some real thought leaders like Ghana, as well as Rwanda, Kenya. We also had countries like Somalia that are just getting started on their health financing journey for NCDs and wanted to learn from countries that have been working on this for several years. So there was an incredible amount of energy in the room. And really some insights from that. All countries are looking for new ideas, new solutions in health financing. Health taxes, obviously critical, but what else? How do different types of insurance schemes work? What are some innovative financing models that have been tried? How to pitch to donors that have not been in the NCD game. Countries are also looking for investment cases to fill gaps in their technologies and human resources, really looking for investment cases to make sure that when revenues are mobilized, to make sure that they don't get lost in the system. They need to be effectively spent on NCDs, and there's some case studies now showing that money earmarked for NCDs is not going to NCDs, which is a tragedy. So how can we plug that gap? And then other countries are looking for assistance on data capabilities, engaging civil society. Somalia is looking for assistance to build a whole new health financing network. And again, they can learn a lot from countries like Ghana that have been on this journey. So we were really pleased to see that model working so well. We want to continue to develop that. Again, we think that progress happens when countries are engaged, listened to. We really understand what's happening locally, where the opportunities lie. There's no one-size-fits-all solution here, but I think if we provide targeted, locally relevant assistance, we can help countries move the needle. And now is the time where we need to act.
Thank you. I think we have time for a very quick second fire round. So if you could all just let the audience know, what is the single most important step that, whether it's governments, multilaterals, private sector needs to take to really make significant progress on this topic? Starting with you, Victor.
Just one thing, leadership.
Thank you.
I'd say yes, leadership, but I think when we look at PPPs, we need patient capital in that. If we look at Ghana, so much to learn and such wonderful use of health taxes. But then if we look at a country like Malawi, where 98% of its resources are going to service its debt, that's a country that's going to need more support and more time through partnerships and through external resources. So differentiating the approach is critical. One size fits all is really not going to work with health financing. Thanks.
Thank you.
I would say in a world with a lot of noise, we have to have one voice, one ask. It's health taxes, it's the health equity force multiplier, and it allows us to finance for the future.
I think for me, it's a shared understanding of the challenge facing us with health financing today, but at the same time, the need to act on NCDs. So how do we come together? I like what Dr. Frieden said. If Coke and Pepsi can come together and find common ground, we in this room have to do at least as good a job or better, and the time to act is now.
Thank you. Would love to welcome everyone. Just thank you, the panelists, and this was a great discussion. Thank you so much for your time and energy. And I'll hand over to you, Alan, for the Q&A.
Really appreciate it. You know, when I turned 50 3 months ago, everyone kept saying, you know, that it's time to get readers. And I said, no, it's not time to get readers. I don't need readers. My eyes are perfect. And I now realize it's time to get readers because I have to apologize, Dr. Jashi, that on my notes it said Dr. Joshi, because that A, I swear it was an O. But Marianne, you pointed that out nicely. So yeah, let's do some, really enjoyed that conversation. We'll take a few questions. If people have questions in the audience, would love it. Well, we have one already. And you're welcome to ask the folks on stage, or you're welcome to ask our first panel, which is here. But please go ahead. Do we have a mic in front of you? Yes, we do.
Thank you. Good morning, everyone. This is Jackie Malouf from the International Diabetes Federation. Wearing several hats, but my question stems from me being the founder and president of a small diabetes organization in Lebanon. So we heard about the challenges of financing in normal settings. I would like all of you to imagine what those challenges would be in a country like Lebanon or Gaza or Ukraine, or whenever the humanitarian crisis is so big that people stop thinking about food and think about insulin or medication. And I've had those comments when we went through very difficult situations. So I don't believe in readiness. I think it's a myth. I believe in preparedness. So what would be, and that's for all the distinguished speakers, and thank you for the very insightful thoughts. So what would be your recommendations to be better prepared? I guess we will never be ready for any humanitarian crisis. We don't want to be ready, and we will not be able to be ready. But if we are prepared, at least we can deal with it in a better way. And I could tell you many, many stories that will really shock you, but I will stop here and would be more than willing to hear your recommendations. And thank you to Devex for this very important event. Thank you.
Well, thank you. And also thank you to our partners. It's not just us. There's a whole community putting this together. But Marianne, I think you wanted to.
Yes, and thank you so much for the question, because I think it speaks to how we can do things that have multiplier impact and effect. So for example, and I'm sure, you know, again, Ghana is on the stage here, what they've done to digitize healthcare and healthcare delivery systems and make sure that everybody is connected digitally to, for example, the health insurance scheme. When you think about investments in digital identity and the ability, if there is a breakdown in the state, you know, if there is a humanitarian crisis, if those digital pathways still exist, we can figure out how to get financing to somebody's mobile wallet, you know, and they can figure out how to buy insulin from many of the e-pharmacies that, you know, are coming out of the impact investing world. And so I do think it's possible, but it's really about focusing on those fundamentals and strengthening those, you know, foundational, I would say, data systems that enable all of this to happen, including financing to flow between the different actors in the market.
Any other thoughts on that?
Thank you. Just to build on that, and I really sympathize with you and the situation that's going on in your region. In the region of the Americas, what affected by really would be natural disasters, hurricanes, volcanoes, earthquakes, and also what the COVID-19 pandemic showed us that we weren't prepared. So going forward, we want to prepare for natural disasters, any sort of crisis, and we've used the regional revolving funds, the pool procurement mechanism that I spoke of before, to build a relationship with suppliers so that we have reserves, or that we know who to speak to in a crisis situation or in a disaster situation very quickly, so that we can mobilize resources to get equipment, medicines, for example, to our member states, and also to have a stockpile in strategic areas within Latin America and the Caribbean so that we can access readily to serve our member states in a situation of crisis or disaster. Thank you.
Thank you. And there's another question. That's an inquisitive table there. Go ahead.
Yeah, thank you very much, Peter Schwartz, President of the International Diabetes Federation. Thank you very much for this brilliant discussion we just had here. If I give lectures about taxes on food, I always use Pakistan as an example, because Pakistan a few years ago, they have achieved, after a very difficult process, a tax on sugary soft drinks, including those with artificial sweetener. And I remember the night before the decision that more than 300 civil society organizations signed letters to the president and the Minister of Health. The Minister of Health was not the problem. He was agree, but Minister of Finance, he was forced by the cooperation of the red and the blue cola producer not to allow this. And it finally succeeded. So a 20% tax on sugary items and a ban around schools not to sell fried food products. So it's fascinating to have this. But now being in Pakistan, they tell me, it's very difficult to implement. It's again the big friendship between the blue and the red producers trying to delay the implementation process, finding barriers, generating barriers. And this is something I think where the international organizations should stand together to tackle this. But what is the recipe to go ahead? And this is where we are some paralyzed in the moment, not to know how to support the implementation of this process.
Great. Someone want to take that one? Okay, Dr. Jashi.
Again, going back to the example of tobacco taxation, my very good friend, who was the chair of the Health Committee in the Parliament, Dr. Årehed, he championed the tobacco control policy and taxes. Initially, yes, I could just see how you described, all the barriers that were created by trying to reach to the policymakers, try to delay implementation of the policies. It takes time, but again, I believe that the best investment you can make is to invest in, again, creating the public acceptance of the problem. When the general public will realize the importance of the sugar, taxation or any other same taxation for the health of their children and the future generations, that will happen, but it takes time. So communication would be the key in terms of overcoming. Otherwise, counteracting those kind of efforts to intrude in the policy making and the implementation factors would be less effective. So engage media, engage opinion leaders, and engage experts. That would be the advice.
Great. Thank you. I think we have time for one more quick one, and I think that right there. Yeah, I know.
Thank you very much. Ben Lautrup, World Diabetes Foundation. We saw in the introduction, Helen, you mentioned about 5 years ago and today, if there's one big change or one big progress compared to 5 years ago with today, it's primary healthcare focus, integrated primary healthcare focus, strengthened primary healthcare. Look at the political declaration that's going to be endorsed in 3 days from now. 4 or 5 pages with the topic, strengthened primary healthcare. So there must be an interface with that financing mobilization that we are discussing today. I would really like to hear reflection from the panel. How will that mobilization have that interface with this strengthened primary healthcare? I think it's the top 1, 2, 3 question of our time, this time in New York. So this would really be valuable to hear your thoughts about. Thank you.
All right, who wants to speak on that?
Yeah, no, I think so. This has been a difficult challenge for many countries coming out of COVID, who really saw that primary healthcare was the key foundation that needed to be in place to assure universal health coverage and lowest possible cost, but highest possible quality of care for their populace. And with NCDs, there's been a lot of questions and a lot of challenges in terms of how to implement or execute against it. I think in part because there was previously more of a focus on maternal newborn child health through primary health care, and then separately infectious diseases were often, as we know, siloed through other investments. And so quite a big task to bring it all together into one package. And though there are many countries that are doing that right now, those reforms are underway. And so it's more of a question of what's in and what's out of the primary health care package, what gets financed. And what I see is that it is incremental, right? In a country like Malawi, what gets covered in their benefits approach through primary health care may not be the same extent as what Ghana is delivering right now. But there are these amazing blueprints or pathways that have been established through countries like Ghana, Rwanda, Kenya, with a lot of complexity in the reforms, and great involvement from civil society and articulating what they need and what they want. But I feel very optimistic. I think we do have so many great examples, and really it comes to Herb's point around just smart technical assistance, learning exchanges, where that can just help accelerate adoption of primary health care that includes all the elements of NCDs that can be covered in a specific country.
Go ahead, Vicky.
Say something very quickly. I couldn't agree with you more. And one of the things I didn't point out was that in Ghana, we're also embarking on a free primary healthcare program, which is actually having a basic minimum healthcare package free of charge wherever you're, because we want to attain universal health coverage. So we're doing what we are calling an end-to-end health coverage. So free primary healthcare, the regular national health insurance scheme, and then the coverage of the non-communicable diseases. But the key for us is make sure we pick them up quickly through the free primary healthcare. So, that's what we're doing. In a few years, we'll be able to see where it goes.
Great. Well, with that, thank you all again. We really appreciate it.